think we are going to move to the next session. Thank you again very much, Professor Izzat. Thank you, Professor Abir.
Welcome, Alan. Hi. Please unmute.
Fantastic conference.
Hi, how are you, my friends?
I'm doing very well. This was an impressive talk. It was a very thorough review of the guidelines and the consideration in the elderly in IBD. So I'm glad I caught this talk, and I want to thank you and congratulate you on this wonderful course.
Okay, thank you to share our IBD edu course this 7th wave, and we are one of the key person in IBD in globe, as we said all time. And with all respect, we are introducing you to this lecture. I know that you are at the early morning now before going to work, but I know that all of us waiting for your interesting talk. Let's go directly to your talk, please.
Thank you. Let me make sure I know how to share my screen. All right, can you see my slides?
Yes, welcome, as we said.
Fantastic. All right, so my goal this morning is to review with you the management of acute severe ulcerative colitis, what we used to call fulminant colitis. So these are our patients with ulcerative colitis that are in the hospital because of a severe flare. So I thought we could start with a case really to highlight some of the patients that we would see in the hospital. This is a 25-year-old woman. She used to be a smoker. A few years later, after she stopped smoking, she developed ulcerative colitis. And it's a pancolitis involving the entire colon for the last 2 years. She actually has been doing well on mesalamine and mercaptopurine. Sometimes she has minimal symptoms that are controlled with budesonide. But now she comes to my clinic with a complaint of 10 bloody bowel movement per day, urgency. She lost a few pounds during the last few weeks. And on history, she does not have any travel history. Now with COVID, nobody's going anywhere. And no history of taking antibiotics. She sometimes take anti-inflammatory for joint pains, but she's been in high stress with work and kids at home, etc. So we give her prednisone 40 milligram, but she does not improve. And now she's having a mild fever and she feels dehydrated and tachycardic. So what I really want to review with you is when we are assessing a patient with ulcerative colitis, how do we look at their disease? First, it's important to see how is our patient doing today? What is the disease activity now? What are the acute symptoms, whether the GI symptom, but also it's important to remember non-GI symptoms. So a patient coming in with a flare, but also with joint pains or with a uveitis, it's important to assess these things quickly, and they can be a sign of severity of what's going on in the bowel. And also we do need objective markers of inflammation. So again, a patient coming in with a flare, it's important to assess their CRP or fecal calprotectin, because that can give us a sense of how severe the inflammation is or is going to be. It's important to remember that often CRP and fecal calprotectin are predictor of how the disease is going to evolve, are predictor of flares, are predictor of how much the severity of the symptom can evolve. But also it's important to listen to the patients. This is what we call patient-reported outcome. Some patient might have 4 or 5 bowel movement per day, so we would think of them as not having too much of a severe flare. But if it's debilitating, if they're not able to go to work, if they're not able to get out of bed, if they're always in the bathroom, if they're afraid to leave the house to go grocery shopping or pick up their kids from school, this is important to take into consideration. And this is a marker of severity. So we see the patient, what are the GI symptoms, what are the extraintestinal manifestation, our objective marker, and how is the patient feeling and doing. Then it's important to look at their history. What has been going on before? If these are patients that have been under amazing control for a long time, we look at these patients differently Then if this is a patient that has a history of having severe flare that require hospital stay, if this is a patient that traditionally does not respond to oral prednisone. So it's really important to see how their disease has evolved up to this point in assessing their disease severity. And finally, putting all this together, what is the risk of colectomy in this patient? What is the risk that we will not be able to control the disease if we don't control the disease quickly? What is the risk that this patient will go for surgery? So young patient who have extensive disease, if patients have had recent scope or at the initial scope of diagnosis, you have seen deep ulcers, this tells you this patient can progress very rapidly toward fulminant colitis and the need for surgery. If a patient has a history of being in the hospital, of having C. diff infection, CMV infection, again, that put the patient at risk of colectomy. So keeping these things in mind, let's look at the new ulcerative colitis activity index that was put out by ACG. If you remember the traditional Love-Hewitt activity index, we focused on number of bowel movement per day, blood in the stool, hemoglobin, and sed rate. In the new activity index put out by the ACG, one more clinical symptom was included, which is urgency, which we know is a big distressing symptom for our patient, the need to constantly go to the bathroom, but also it is a marker of the severity of the inflammation in the rectum. Severe proctitis will give you great urgency, and so it's important to listen to the patient telling you, I go 15 times to the bathroom, but most of the time it's just a little bit of blood, a little bit of air. I have 3 or 4 bowel movement per day. Otherwise, that urgency is a marker of severe inflammatory burden of the rectum mainly. But also in addition to sed rate, which we know can be elevated if we have anemia or for other reason, CRP was added, but also fecal calprotectin. So fecal calprotectin is our inflammatory marker in the stool. It's a marker of inflammation in the colon, and it's more specific to bowel inflammation than a CRP. Unfortunately, fecal calprotectin takes several days to come back. So we still rely on the CRP as a marker of inflammation. It's a quick lab that comes back, but it's also fecal calprotectin is more specific, more sensitive. So for example, if you have somebody in a flare, but also have joint pains, the CRP can be very elevated because of the joint inflammation, the arthritis. The fecal calprotectin will give you a better sense of what's going on in the colon. And also it's important to remember that some patients with inflammatory bowel disease don't mount a CRP response. The CRP can remain normal, and you really have to rely on the fecal calprotectin to assess the inflammatory burden in the colon. But very importantly, what was added to the activity index is what we see on endoscopy. So, a few years ago, we just rely on symptom and some labs, the hemoglobin, if there's anemia or not, the inflammatory markers, CRP and sed rate. But it's important to remember that the endoscopy score is very important in telling us how severe the disease is, and whether you're using the Mayo score or the UC EIS, whatever you use in your practice. When you're doing an endoscopy report, make sure you use that, because then that helps you, if the patient transition care to another physician, to another location, you know that this patient had Mayo scores 3 at some point or Mayo score 2. So you know that this is a patient that have a more severe disease to be taken more seriously. So our patient here with 10 bloody bowel movement per day, with also some mild temperature, and it definitely belongs to the moderate or severe or even fulminant ulcerative colitis. And that helps us assess if this is a patient that needs to be in the hospital. Anything moderate, severe, fulminant, this is a patient that needs to be admitted. Or if this is a patient you can treat as an outpatient if they have more mild disease activity, or that you could treat with a close follow-up in clinic. So our patient belonged to the hospital, but it's always important when a patient with UC has a flare, whether this is a patient that belongs to the outpatient clinic or to the hospital, to assess the cause of flares. And flares could be due to many things, whether it's non-compliance, this patient was on mesalamine and mercaptopurine, and we know that patient compliance with oral medication is not great. We all forget to take a medication every day. So in a situation of stress, there's a higher risk of being non-compliant, but patients often report that stress can trigger a flare. And if you look at the old literature, And when we were in med school, they would tell us, oh, stress has nothing to do with IBD flare, but it does. Our patients tell us that it does. And now understanding the gut and brain axis and the gut microbiome, we know that stress actually changes the gut microbiome and triggers inflammation. NSAIDs can trigger a flare, but also it could be just a natural history of the disease. These are diseases that are unpredictable, and a patient who has been doing well for 2 years can suddenly find themselves in the hospital with a severe flare. But the most important thing to do always is to rule out infections. And whether these are bacterial infection or C. diff or CMV, it's always important to rule out infection. The most common infection we're seeing now as a cause of flare for UC or Crohn's disease is C. diff infection. But also it's important to remember that Salmonella and Shigella can actually cause a flare. And if you scope these patients, the colon can look exactly like a UC or Crohn's flare. So I always send a stool culture, a C. diff. And in a patient who's hospitalized, especially if they have been on prednisone and not getting better, it's important to think about CMV. So let's go over that. So C. diff in recent years has been really highlighted as a complicating factor that triggers a flare in a patient with IBD, and that we see more and more in a patient with IBD that are admitted to the hospital. So if you look at that curve, the top curve, we see that in recent year, we see more and more C. diff, and including mainly in patient with ulcerative colitis, but also in patient with Crohn's colitis. So always check for C. diff in your patient admitted with an IBD flare. C. diff can cause up to 20% of IBD flare, and the demographic of C. diff in IBD is different than what we see in the general population. So typically C. diff is something that we see in older patient, in nursing home patient who have been in the hospital, patient who have taken antibiotic. But in patients with IBD, C. diff can occur in the young, without a history of antibiotic. These are patients that are out in the community. But what we know as a risk factor is steroid use. So patients on steroid have a 3-time higher risk of developing C. diff. And in contrast, patients on biologic are not at increased risk of C. diff. So this is always very important in any discussion that we have, and Professor Izzat Ali mentioned that also in his talk, that steroid is always the worst treatment that we can give to our patient. This is really the medication that is associated with a higher risk of infection and morbidity and mortality. And that's a discussion important always to have with our patients that are afraid to take biologic, that actually biologic, by putting their disease in remission, decrease their risk of infection. We see C. diff more commonly in patients with colon disease, so ulcerative colitis or Crohn's colitis, but important to remember that we can also see it in our patient who had a colectomy and a pouch, or colectomy with end ileostomy. So C. diff and IBD can exist in the small bowel and in the pouch, something to remember. So how does the colon look in C. diff with IBD? So on your left is a C. diff in a non-IBD patient, where you recognize those thick pseudomembranes of the colon. As soon as you put the scope in, you know this is C. diff. In our IBD patient, 90% of the time, there's no pseudomembrane. It will look exactly like a UC flare. So the lack of pseudomembrane does not mean that there's no C. diff, so we shouldn't be fooled. So it's our stool study that will tell us if this patient has C. diff or not. Why is it important to diagnose this? Is because C. diff severity in IBD patient is much higher than non-IBD patient and increase the risk of colectomy. So your ulcerative colitis patient with C. diff in the hospital has a 6-time increased risk of colectomy than if they do not have C. diff. So these are patients that we need to treat quickly, that we need to watch, that we need to have surgery on board in case they don't do well. Also, our patient, IBD patient, has a higher recurrence rate of C. diff within the year, and their risk of death or colectomy after being hospitalized is increased at 5 years. So our patient with IBD who had C. diff once, even if we treat them, this is always going to be a marker of severity for them in the future. So when you assess them later, if they have a flare or etc., this is already a patient that you can mark as potentially having recurrent C. diff, potentially needing colectomy in the future. But the trick here also is that IBD patients are often asymptomatic carrier of C. diff. So around 10% of IBD patients can carry C. diff and not be symptomatic, which brings us to the point of when we're diagnosing C. diff, it's important to try to differentiate if this is an active infection that needs to be treated, or if it's just a colonization and the symptoms are actually only due to an IBD flare. Which brings me to the importance of what tests we are ordering, okay? So it's important to order the right test. There are many tests for C. diff. The GDH look for the organism. It tells you the organism is there, whether it's producing toxin or not. If your GDH is negative, you don't have the organism, there's no C. diff. If your GDH is positive, we need to know if the toxin is produced. And this is where we use the ELISA test. If the ELISA test is positive, then this is C. diff and it needs to be treated. If the ELISA test is negative, this is when we should do PCR. And if the PCR is positive, then we should treat for C. diff. So the best combination of tests is a GDH with ELISA reflex if the GDH is positive. Unfortunately, many hospitals and many labs will only do the PCR. And the PCR positive just means that we have the genetic fragment that makes a toxin, but it's not the toxin. It's the ELISA that detects the toxin. So PCR only being positive could be colonization. Now, in the right clinical context, we should treat if the PCR is positive. If that's the only test that we have available, we should treat. But it's important to know your test so that if you have a patient with like PCR keep coming back positive, that might be just colonization and not infection. So what do we do? If there's a high suspicion, if I admit a patient who has a history of C. diff in the past with a flare, I'll send the stool test and I will start treatment for C. diff. Don't wait for that stool test to come back. If there's a high suspicion, start your C. diff therapy. The recommendation now is to use vancomycin. We do not use metronidazole anymore. Metronidazole has a high failure rate, so it's important to use the right therapy, which is vancomycin, 125 milligram, 4 times a day, traditionally for 14 days. But we're having more and more data. David Rubin looked at that. And there's more and more data that our patients with IBD need a longer duration of treatment. So if I'm seeing a patient on the outpatient or the inpatient setting, and I start on vancomycin and they respond, I use for at least 3 to 4 weeks, okay? So more than 14 days, more than the traditional C. diff treatment. If they have severe C. diff, if this is your patient in the ICU, they're in shock, that's the only time that there's an indication to use a higher dose of vancomycin in combination with IV metronidazole. So oral vancomycin with IV metronidazole. And if this is the patient is sick like this, surgery need to be on board. These are, again, patients that are high risk of needing surgery and colectomy. All right, so how about you have your patient, they're flaring, they have C. diff. Should we treat the flare also or only C. diff? I just told you that steroid increase the risk of colectomy with C. diff, increase the risk of mortality when we have C. diff. So what should we do? The ACG guidelines from a few years ago said when we have a patient with C. diff in the hospital, we should avoid using steroid or anti-TNF for 72 hours and use these 72 hours to treat for the initial treatment of C. diff. However, a more recent study, the IBD remedy study, which is a multi-center study retrospective of multiple hospitals in New York, looked at C. diff and IBD, and they looked at the 90 days clinical outcome of IBD with C. diff in more than 200 patients. And they looked at patients that had treatment escalation, meaning that in addition to treating their C. diff, they received anti-TNF. And they looked at patients where only C. diff was treated and escalation to anti-TNF was delayed by more than 13 days. And this is what we have. Look at the column of no escalation. So these are patients that got treated for their C. diff and we waited to treat the underlying IBD flare. And then next to it, we have the patient that were quickly escalated to anti-TNF to treat the underlying IBD flare. And death, sepsis, colectomy, and overall severe outcome was higher in patients where we only treated the C. diff and delayed the escalation to treating the underlying IBD flare. So from this study, this is what I do. If I have a patient who gets admitted with a severe UC and has C. diff, I start C. diff treatment. If there's no improvement after 48 hours, I escalate. So typically this is anti-TNF or steroid or combination of both. And if the patient does well, perfect. We complete the C. diff treatment, again, more than 2 weeks for most of our patients, and taper off the steroids. If the patient is improved after 48 hours, then we just focus on the C. diff infection. This is a trigger, and we don't have to treat the underlying IBD flare. How about FMT? You have your patient with C. diff. They're not improving with C. diff therapy. They're not improving with underlying IBD flare. Should we use FMT? And the results are controversial, but most of the time what we have, these are small studies, and also the way of the delivery and the type of stool that was used are all different, and the number of FMT is different. But overall, if you look at these studies, patients do improve. The C. diff is around 80 to 90% with FMT. And there were no patients that flared who had Crohn's disease because of FMT, and only one of the 23 patients with UC flared with FMT. So FMT is something to consider if your patient has recurrent C. diff and they're admitted again for C. diff and an IBD flare, and you can get them better, think about FMT. How about CMV? This is a conversation we had on Monday Night IBD on the Twitter handle about IBD and CMV, and there were a lot of discussion, and this is the algorithm we came up with. Basically, most of us as adults have a positive serology for CMV. So serology is not very helpful unless it's an IgM serology. So you have IgM positive, meaning it's a new infection, but typically in our patients with IBD, their serology is going to come back positive. So we cannot rely on that part. So what we're going to focus on is a FlexSig with biopsy. So in your patient with severe UC being admitted, especially if they've been on steroid, they are high risk of having CMV. This is what we're going to do. We're going to biopsy, and typically where CMV live is at the center of an ulcer. So if on colonoscopy, and actually you don't need to do a full colonoscopy, on FlexSig for a UC patient, you see deep ulcers, you want to biopsy the center of the ulcer and send for immunohistochemistry. If the pathologist see viral inclusion or cellular changes compatible with CMV, then you know you have active CMV and you need to be calling your infectious disease colleague and start treatment. All right, so let's go back. Now, this was all the background. We have a severe patient. We're thinking infection. We're on day one, they come in, we check baseline labs, albumin, which is a marker of severe inflammation if it's low, CRP. We send fecal calprotectin, but knowing this is going to take a few days. So fecal calprotectin is really for later, looking at the progression later, but CRP is what we can get quickly. And I always send off, if the patient has never been on anti-TNF, like my patient here who was on 6-MP and mesalamine, I send off labs in preparation for using anti-TNF. So our hepatitis B serology and a quantiferon gold to check for tuberculosis. I now moved away from checking a PPD because PPD is not very reliable in someone who's already on prednisone or steroids. It can be falsely negative. And also it relies on the fact that we have to do a read after 2 to 3 days. So we do send the labs for quantiferon gold to check for tuberculosis. And again, very important to send stool studies, including C. diff. Don't wait for the C. diff result. If you have a high suspicion of C. diff infection, start treatment. And a FlexSig with biopsy need to be done within the first 24 to 72 hours of admitting the patient. So these are the new recommendations that we really need to be early on top of things. How do we treat our patient with acute severe UC in the hospital? We need high dose steroid. So pick the one that is your favorite. I use methylprednisolone at 60 milligram IV daily, but you can also use hydrocortisone 100 milligram 3 to 4 times a day. The reason I say it's important to be consistent, because what I've seen, unfortunately, sometimes with our fellow or resident, they use methylprednisolone 3 to 4 times a day. So methylprednisolone is once a day, hydrocortisone 100 milligram 3 to 4 times a day. Pick one that you're comfortable with and use it. In addition to that, it's very important to think DVT prophylaxis, including in our patient coming with a UC flare and bleeding. Using heparin sub-Q is not going to increase bleeding in our UC patient. UC patient with a severe flare, they have a higher risk of clotting, of developing DVT in the lower extremity, or splenic vein thrombosis, mesenteric vein thrombosis, and PE. So all the patients admitted with a severe UC need to be started on DVT prophylaxis. It will not increase their risk of bleeding. How about antibiotics? We used to put patients with a severe UC on antibiotic, typically Cipro and metronidazole, but we just talked about how they are high risk of C. diff, so we do not want to add antibiotic if we don't need to. The most recent ACG guideline recommend against antibiotic in a severe flare unless the patient is in sepsis and not doing well. In my practice, I have to say that I have seen that using antibiotic, if the patient does not have C. diff, decrease hospital duration, and studies have shown that using antibiotic does decrease hospitalization duration. And in my patient who are tachycardic and with a fever, I do use antibiotics if C. diff is negative. And I feel that that decrease the bacterial translocation from the bowel into their stream and make them feel better. One reflex that I often see in our resident is that we put everybody on bowel rest, NPO and TPN, and we shouldn't be doing that. Our patient can have diet as tolerated. There's no need for bowel rest unless they're coming in with severe hemorrhage or toxic megacolon and they're going to go for surgery. This is when you put them at bowel rest. But otherwise, if you tell them not to eat, the next day you're going to come in and they're going to say, I only had 2 bowel movements. So you're going to think they're doing fine. You'll discharge them. And then they call you from home that they're back to having 10 bloody bowel movements per day. So diet as tolerated, a soft diet, whatever they feel like eating. In terms of managing pain, it's important to avoid opioid and morphine and dilaudid. They can really increase the risk of a megacolon. And it's important to monitor our patient with serial exam, monitoring for toxic megacolon, where the colon is enlarged and when the patient develop sign of toxicity. When do we reassess? It's important to reassess very quickly, as early as day 3. By physical exam, what are the number of bowel movement per day? What is the blood in the stool decreasing? Is the CRP dropping? So I usually check all this at day 3. I repeat the CRP. And this is how we're going to assess if our patient is moving in the right direction. If all this is improved on IV steroids, then the patient can be discharged on oral prednisone, and then you can manage the rest on an outpatient basis. You can decide if you're going to change therapy, if you're going to change from a non-biologic to biologic, if the patient was already on biologic, if you're going to change to a different mechanism of action. But if the patient is not doing well, like my patient, still having multiple bloody bowel movement per day, CRP still elevated, not tolerating PO intake, then we need to do something different. So what's next? Always have your surgeon on board. If your patient is not doing well by day 3, call your surgeon. You might not need them, but they need to be on board. And actually, it's even better to call the surgeon from day 1. Just let them know about the patient. Let the patient know that we're going to have surgery on board. It does not mean you need surgery, but it's important to have the whole team on board. So if the ulcerative colitis does not respond, if you develop toxic megacolon, if there's severe colonic hemorrhage, the surgeon already know you, talked to you, and went over things with you. So it's not a surprise. We're not rushing the patient to the OR without prior discussion. And now this is the time to escalate therapy. And we have traditionally 2 choices, infliximab and cyclosporin. But now also we can think about tufasitinib as an option, and we'll go over that. So just let me refresh your mind about the risk factor for colectomy. If this is a young patient, if they were non-smoker or ex-smoker, if they have a fever, if they have peripheral manifestation, if they have high CRP, low hemoglobin, low albumin, all these are criteria of severe disease. If when you did Flexig, you saw deep ulcers, if they have CMV or C. diff, these are high risk of colectomy. You need to have the surgeon on board. So let's look at our 2 traditional options, IV infliximab or IV cyclosporin. For IV infliximab, typically 5 to 10 milligram per kilogram for the first dose. If they respond after the first dose, fantastic. They can be discharged on infliximab, and then you can add immunomodulator with it or not. For IV cyclosporin, you need to use it with steroid, and if we induce remission, then they can be transitioned on an outpatient basis either to azathioprine if they've never been on azathioprine, or now to vedolizumab. If your patient does not respond to infliximab or to cyclosporin, this is a time for colectomy. We don't go from one to the other. So if your patient failed IV infliximab, going to IV cyclosporin is very high risk of infection and mortality, and vice versa. So you have to pick one or the other. So for infliximab, the studies that we have in acute severe ulcerative colitis show a response rate that varies between 50 to 100%, depending on the cases and depending on the dose. And those that have been used vary from the traditional 5 milligram per kilogram up to 20 milligram per kilogram, with the idea that patients who have severe disease, low albumin, a high CRP are going to lose protein in their gut and lose infliximab also. So that is why often in our patient with acute severe or UC with low albumin, high CRP, if we're going to use infliximab, we're going to use a higher dose, 10, 15. I have never used 20 milligram per kilogram, but some have, but use a higher dose so that the patient can retain some infliximab and make it effective. The colectomy-free survival with infliximab is 70% at 1 year, okay? So now, is there any benefit in our severe patient to give them one dose and then instead of waiting 2 weeks later for the second dose, if they don't do well, to give them another dose at 5 days and another dose at 5 days? The data actually has shown that there's no benefit to accelerated dosing regimen. So when we collect the entire data, retrospective data on those that had an accelerated regimen, where after the first dose in the hospital, they didn't do well, we gave them a second dose 5 days later, it does not seem to delay or decrease the incidence of colectomy. So I think we need to be very selective in who we're going to do that for. And sometimes delaying surgery by keep giving infliximab, we are doing a disservice to the patient and making them sicker, and then poorer candidate to surgery and a high risk of complication from surgery after being malnourished and on steroid, on infliximab for many days before sending them to surgery. So use an accelerated dosing regimen judiciously in the patient that you feel is getting better, but not perfect yet. These might be the ones that benefit from accelerating dosing. How about IV cyclosporin? Think of cyclosporin in your patient that you think would not respond to infliximab. So your patient with low albumin, high CRP. So, but also you need to be in a center and be comfortable using IV cyclosporin. It's used as a continuous drip in addition to steroid. Trough level has to be checked at 48 hours, and the goal of the trough level is between 300 and 400. And you should put your patient on a PJP prophylaxis, what we used to call PCP prophylaxis with Bactrim. And cyclosporin, as you know, has many potential side effects, including seizure and renal toxicity. So you really want to monitor the patient very carefully. But in terms of result, it has similar result than infliximab. Around 60% will avoid colectomy at 1 year. If the patient responds to cyclosporin, then you discharge them on oral cyclosporin. They're going to be on it for several weeks with a steroid taper. And then as you're tapering off steroid and you're getting ready to stop cyclosporin, your exit strategy of azathioprine or vedolizumab can be started. How about tofacitinib? So tofacitinib has been approved for UC at a dose of 10 milligram twice a day as an induction dose and maintenance dose of 5 milligram twice a day. There are small case reports that use tofacitinib in acute severe UC, mainly a great option in your patient who's already on infliximab. If your patient is already on infliximab and now they're failing infliximab and they're here with severe UC and they don't respond to steroid and you don't want to send them to surgery, tofacitinib can be an option used at higher dose. So in those small case report, it was used as 10 milligram twice a day or 3 times a day or 15 milligram twice a day. So higher dose around 30 milligram per day. And in this small case report, there was rapid improvement of symptoms, a drop of CRP, and patients were able to avoid surgery. So something to think about in your practice, if you have someone who already failed infliximab, you do not want to use cyclosporin, and you want to try to avoid surgery, this might be a good option. All right, so I'm gonna summarize quickly. When we are dealing with a patient with UC, assess disease severity now. What was their history up to now that tells you that this patient could be at risk of needing colectomy and we need to act quickly? And recognize the disease severity now and the risk of colectomy historically, and decide if this patient belongs to the hospital. Once your patient is in the hospital, make sure there's no infection, mainly C. diff if positive, oral vancomycin is now the treatment of choice. Check your baseline labs. Albumin, hemoglobin are a marker of severity. And check your infliximab prereqs of hepatitis B and TB if your patient has never been on infliximab before. Do your Flexic within 24 to 72 hours to rule out CMV. DVT prophylaxis is very important. People often forget about it or are worried about it, that it might cause more bleeding. It doesn't. So put your patient on DVT prophylaxis. Start high-dose steroids, serial abdominal exam, repeat assessment in 3 days. If CRP and symptoms are not getting better, move on to plan B. Antibiotic maybe in certain patients, and then PO intake as tolerated. If there's a failure of steroid after 3 days, have your surgeon on board, choose your next therapy. And if your next therapy is not improving the patient, do not delay surgery. The more our patients are sick and malnourished, the more we have surgery complication. And unfortunately, some patient, a proportion of patient, despite all the therapies that we have, will still require surgery. If their response to infliximab, they are maintained on infliximab. If their response to cyclosporine, they transition to a maintenance therapy. If they respond to TOFA now, they will stay on TOFA. So I'm going to stop here and tell you that IBDologists are cool people and they act fast and strong. And it's important to remember to do that in our patient with active acute severe ulcerative colitis. Do not delay effective therapies.
Welcome again, Alan. We have to know that this elegant lecture from our Professor Alan Sharapati, that is a clinical director of gastroenterology division, director of IBD Center at Johns Hopkins School of Medicine. She has the very creators for the IBD. She is a create what's called Monday Night IBD as the Twitter. She has play role and a very good, strong platform for all IBD interested people, and they play a role as an advocate and helping a lot of advocates in the IBD to play a role. Also, she is the chair of Greater Washington, D.C., Virginia Crohn's and Colitis Foundation. Also, she received the Excellency in the Medicine Award, CCFN 2020. I think we are proud to hear you and to listen for this elegant lecture. And I think you have a lot of questions before going work now. Yes?
Thank you, Professor Ali, for this very nice introduction. And I'm going to tell you, I am so, the one thing about Twitter is that we were able to connect with an international community and share experiences and learn from each other. And we always appreciate your input on Monday Night IBD. And I think the biggest pleasure I have is really connecting with amazing people that are working into raising awareness for IBD and providing the best care for our patients.
The first question is a COVID-19 zone question. You know that is some cases of COVID-19 showing some IBD-like features. And what about how to deal with, how to think, how to expect that is predominant COVID than IBD or UC flare?
This is a great question. And if you probably are aware, there's a registry, the Secure IBD registry, that has been collecting data on patients with IBD that have COVID to better understand how COVID affects patients with IBD. So what we know now is that COVID can manifest with GI symptoms of diarrhea and vomiting. And more so in IBD patients. So if your IBD patient presents with symptoms that are not typical of their flare, so if your patient typically has pain and blood in the stool, and now suddenly they also have vomiting and fever, you have to think this could be COVID. If they also have other symptoms of fever, or they had contact with someone who had COVID, you have to think COVID. Now, how do we treat that? The recommendation is that depending on the therapy, we either hold it or keep it. So, and this is a theory, because in practice, even if you hold thiopurine, or if you hold infliximab or ustekinumab, the effect of these drugs are still in the patient body. So if the patient has COVID infection and they're due for an infusion or an injection of a biologic, you can hold that for a couple of weeks until they get better. But If you are on budesonide or on vedolizumab, you can proceed. The data that we have now is that we can continue these kind of therapies. If your patient has an IBD flare and a COVID infection, it's important to treat both. And there's more and more case series showing that actually controlling the IBD flare is important, and even maybe using anti-TNF can actually help with the cytokine storm of the COVID-19 infection. So I think it's a very tricky situation, and where you have to balance the risk and benefit and adjust to the severity of the COVID and the severity of the IBD flare. If the COVID is mild, I usually don't change anything. I keep everything the same. If they're due for an injection or infusion, I delay it by a couple of weeks. There's no big deal. If the COVID is severe and the patient is in the hospital, we focus on support care of COVID. But if the IBD flares, we have to treat the IBD. And then it's important to remember for our patient that it is being on steroid and have active disease that put the patient with IBD for severe COVID infection. Being with the secure IBD registry show us that being on anti-TNF, ustekinumab, or vedolizumab does not increase the risk of severe COVID. They do better than patients who have active flare or on steroid, or even patient on mesalamine. So it's important now more than ever to tell our patients with IBD to stay on the medication that's keeping the IBD in remission and not stop the biologics, and continue to do well and stay away from the hospitals.
Before I'm shifting to the second question, just say welcome, Professor Hussein Al-Amin is my second chair in our guest lecture. Welcome, Professor Hussein.
Welcome, my dear friend.
Okay, I have Dr. Momin had a question for you, Professor Allen.
Professor Allen, you are welcome, and thank you for this excellent lecture and topic. I have more than one paper, multiple papers about the high dose of infliximab in ASUC, which is better than the lower doses using 10 milligram or 15 milligram, as you mentioned in your lecture. But I'd like to ask you, the risk of colectomy is less in the high dose of infliximab rather than the low dose, but after 1 year, we have higher risk of colectomy in patients with ASUC after induction of remission and maintenance with infliximab. Do you recommend shifting the patient to other biological therapy rather than anti-TNF after using it as a bridging therapy in ASUC in order to decrease the risk of colectomy, or once you have patient in remission, maintain him on infliximab and monitor him? And thank you so much.
This is a great question. And again, thank you all for having me. It's really a pleasure to be here. So I agree with you. In my patients hospitalized with UC, if I'm going to use infliximab, I usually use 10 milligram per kilogram because they are sick, they're going to lose the infliximab. 5 milligram is not enough. The controversy is whether or not accelerating the frequency every 5 days in patients who don't respond to the first one, is it beneficial or not? And the data is not there. But I agree with you that 10 milligram per kilogram is my choice. When a patient is having severe UC and requiring higher dose of infliximab to get better, they're already telling you they are at high risk of colectomy. And like we saw in the data, it might delay the colectomy, but they might still need it. But honestly, I don't think of it as a total failure of our therapy, because it really prepares also the patient to the possibility of a colectomy. It's very hard for a patient admitted with an acute flare. Sometimes this is their first flare, to just being rushed to the OR on that admission. So I think what's important here is to tell the patient, you have severe UC, we got you better on infliximab, but your disease is telling us this is a severe disease. We might still need surgery, but we'll see what happens. Mentally and psychologically for the patient, they will be better prepared, but also in terms of nutrition and physical status, we improve their overall state, and that would decrease the risk of complication for surgery later on if they need it. On the other hand, the patient who require a high dose of infliximab, I'm going to keep a very close eye on. So these are the patients I'm going to monitor the infliximab level during maintenance and make sure they are at the right level, somewhere around 10 of trough level. And I'm going to monitor their markers of inflammation. This is a patient I'm going to monitor fecal calprotectin every 3 to 4 months. So if I see that the calprotectin is increasing, I know I need to do something different because this is a patient at high risk of colectomy. The third thing we can do is combine effort. And in addition to infliximab, have the patient also on thiopurine, on azathioprine or 6-MP, whichever is your favorite, and combine therapy to really optimize our control of the disease. Now, should we switch to something else? Honestly, infliximab is the one that is a biologic that is the most effective one that we have.
The best, yes.
Right. So in our sick patient, if you ask anybody with GI or IBD, in the sickest patient, we're going to use infliximab. If infliximab doesn't work, there's less risk for the other stuff to work, especially in the severe cases. So if our patient responds to infliximab, I will optimize infliximab by following trough level, adding an immunomodulator, following fecal calprotectin or CRP, and adjust accordingly. And always have that discussion with the patient. The patient, we don't want to make them anxious that they are in a bad place, but we want to be objective and prepare them mentally that, you know, we're going to do our best, but it's always important to remember there's a patient that still needs surgery, and it's okay. And it's better than being sick the rest of your life. So always that communication, monitoring, and reassessing.
Thank you, Professor Ali. Thank you.
Professor Izzat, I want to ask a question, please.
Yeah, go, Professor Hussein.
Hello, Professor Anne. Welcome to you, and thank you for very, very nice presentation. I have actually a real case last month, a female patient, 50 years old. She came with acute severe ulcerative colitis. She gives a history of treatment of steroids for many years. And also she had a partial response to Simponi. This patient came with acute severe colitis and received IV steroids. Unfortunately, after 3 days, she developed 2 perforations in the left colon. And the surgeon did for her ileostomy because of the very bad general condition. The patient is now very good on oral steroids now, 25 milligram. What do you think is the future plan of this patient as regards he gives a history of partial response to Simponi? What's the future plan for this patient with ileostomy and history of 2 perforations in the left colon?
Okay, so this patient is high-risk colectomy, right? She's been steroid dependent.
Yes.
She had a spontaneous perforation of the colon, which also have to make you think about 2 things. And that would be great to have some surgical specimen. And I don't know if the surgeon took out some of the colon that was perforated or not, and to examine that specimen well to make sure it's not Crohn's disease. So
Yeah.
anytime you have UC with perforation, it could be severe UC, but also it could be Crohn's. And we know that some patient is difficult to differentiate between the 2,
Yes.
especially when you have not made the diagnosis. It's a diagnosis made a long time ago. We really don't know what was there. So this is a patient anyway already in the severe category. And I think in this case, it's important to have what we call a shared decision, meaning discussing with the patient the option and the pros and cons. If we think this is ulcerative colitis and she had perforation, I would be very inclined to say we're going to do a colectomy and an ileal pouch. And what you can do actually is do that in stages, do a colectomy and leave the rectum, have the opportunity to examine the colon, make sure this is ulcerative colitis and not Crohn's, and then take it from there. Or you can tell the patient you had a partial response to Simponi, and maybe something like infliximab will get you better. And we can consider, resuming bowel continuity and doing infliximab and see how you do. But there's a risk that we're not able to control things and you will still need surgery. So there's no right or wrong answer. I think it's very important to always think about the patient first before the colon. We're trying to save the patient and keep them alive and not have them have another bowel perforation. And this time she did fine and she survived. Next time she might not. So it's always important to think that it's the patient we want to do well and not necessarily the colon. But if we're going to offer surgery, it has to be also the right surgery and make sure that we're doing the right surgery if it's UC or Crohn's disease. So it's important to have this kind of conversation and to think about it. There's no urgency now. Well, I think the fact that she has a diverting ileostomy, we can taper off the prednisone so that whatever decision we make, if we're going to go for surgery, she's on the least amount of prednisone, since steroids can increase the risk of complication from surgery. And since the bowel is diverted now, you know, her colon does not need the steroid. So we can taper down the prednisone and then reassess. Maybe you can scope her, take a look, take some biopsy, get a sense of what's going on. But I think both options are there. She already manifested that she's high risk of colectomy. If she has UC, she already perforated on her own. Doing a colectomy and an ileal pouch is a good option. Or you can say you had a partial response, but also you've been on years of steroids. You know, we don't know if you're going to do better on infliximab, but you could do better on infliximab, and we can do this option. So both options are good. And it's important to have that decision with the patient, because patient might say, you know what, I don't want to ever deal with this being in the hospital and think I'm going to die. Get that colon out, I'm done. Or the patient say, no, I want to try everything, but it's important to have realistic expectations. Things might not work and we might still need surgery.
Thank you.
We have two final questions, one from Dr. Nada Osman, one of the IBG EGU member, and the second from Dr. Dua Haider. Starting, Dr. Nada is also Dr. Dua, one of the IBEGU platform. Dr. Nada, start your question.
Welcome, Dr. Allen, to our 7th EDU wave. I have a question about COVID patients. You are going to continue with biological therapy. Azathioprines, you're going to stop them while the patient is having COVID, when you're going to tell your patient to continue his azathioprine therapy?
It's a great question. And first of all, can I say how excited I am to see so many women on the panel? So you guys are amazing, and
Yes.
it's fantastic to see this.
Yes.
Really, it's beautiful and it warms my heart. And it's, you know, I just want to congratulate you on that.
Woman at diversity, yes.
Yes. I mean, I feel the power here.
Yes.
So in the Secure IBD registry, they published their data recently that patients on azathioprine or mercaptopurine might be at higher risk of severe COVID. And we know that thiopurine increases the risk of viral infection, so it kind of makes sense. So the recommendation now is that if we have a patient on combination therapy, if they are on, let's say, infliximab plus azathioprine or 6-MP, is to see if it's appropriate to remove the thiopurine and just keep the biologic monotherapy if it's the right decision. Again, it's very important, and this is as a prevention of having severe COVID, or if they have, or if they get an infection. If your patient needs both to stay on remission, it's important to keep both. Patients who have a history of very severe disease, difficult to control, and only being on both treatment help, we need to keep that on board, because the worst thing we can do is have the patient flare and need steroid. But again, if they're on combination therapy and they're stable and you can remove the thiopurine, we remove thiopurine. Now, if they are on thiopurine alone and they develop COVID, we know that even if we stop thiopurine effect lasts 2 to 3 months, right? So we stop it, but it doesn't really mean much because the effect is still there. If it's mild symptom, I don't stop it, honestly, because I don't want the patient to flare. I don't want to have to use steroid because that will put them at higher risk. If they are in the hospital, I stop it, but again, we stop it a little bit. It's like a psychological benefit for us because the effect is still there. In our outpatient that are on thiopurine and they come to you and they're concerned that maybe that can increase their risk of severe COVID, you can assess and see if they are candidates for another therapy or stay on the thiopurine, because it's all about risk and benefit when we are trying to make these decisions. You know, if a patient is doing well on thiopurine for years, I'm very reluctant to stop it and say, let's try something else. What if something else doesn't work? So it's a risk and benefit discussion, and this is where you discuss that with the patient and see how they feel about it, because they need to be partner in that decision. and understand the risk and benefit of switching from a therapy that worked to something else, and the risk of if they had get COVID, they might have more severe COVID. Does this answer your question?
Yes.
That's all.
Dr. Dai, ask the question, Dr. Dai.
Okay. Thank you, Dr. Allen, for this elegant lecture. And I have two questions. First question is, biosimilars, do they have a role in acute severe ulcerative colitis management?
That's a great question, and I'm glad you asked, because there's a lot of concern about biosimilar, that they might not be as good as the original. And the data that I have now is that biosimilar actually have the same efficacy than the original. So biosimilar infliximab has the same efficacy as the original Remicade. In our hospital, for example, we switch everything to biosimilar, and it's cost saving, obviously. It costs less money for the health system. And even our patients who were on the original infliximab, we switched them to the biosimilar. So that is very important to remember, that they have the same efficacy, and long-term follow-up, patients on biosimilar from the start, or who were switched from the original to biosimilar, compared to those who stayed on the original, had the same efficacy long-term, same rate of loss of response, same rate of having antibody. The thing to remember is that if you develop antibody to the original infliximab, you should not switch to the biosimilar, because it's the same antibody. And the way to think about it, and what, you know, people that are smarter and like are into molecular biology explain to me, is that even if you look at Remicade, the Remicade that we had 20 years ago is already different now, because the process of making these kind of antibody, there's always a little bit of change that happen. So it's what our patients are getting now, even if they're getting the original infliximab, is a biosimilar to what you were getting 5 years ago in a sense. So if your hospital has a biosimilar version of infliximab, you would use it same as the original infliximab.
And my second question, in 2019, there was a study on 40 patients with acute severe ulcerative colitis, and they used successfully cyclosporin therapy after infliximab failure. What's your opinion about this, Dr. Allen?
Yeah, so this has to be done in a very specific center, and really, you have to really assess the risk and the benefit. And even, I think this study is from the University of Chicago, and even when Russ Cohen and David Rubin talk about this, they say it's feasible, but don't try it at home. So it's something that you could do. But again, these are patients that are telling you they have severe disease. And I think we would just be delaying the inevitable and putting them at high risk of complication and mortality. So unless you have a IBD service dedicated to that, where the monitoring is really on top of things, the patient understand the risks, and we're monitoring everything, and you have infectious disease on board and renal on board and everybody else, I personally don't like to switch from one to the other. I think if one didn't work, I would move to surgery.
Yes. Okay, at the end, thank you a lot, Ellen. But consider our IBD Edu is your platform, as one of the global platform for IBD. And next time we will meet physically, inshallah.
Inshallah, I can't wait.
Inshallah. Bye, thank you.
Thank you very much for having me. Have a fantastic day. Mabruk, mabruk, mabruk on this fantastic course. It's really high quality, and I love the fact that it's a diverse group, and the lecture